Good afternoon, everyone. Thank you so much for joining us in the third webinar of our three-part series on the Policy and Procedure Playbook. We
We
are,
we are
hold on, I'm having some feedback.
having some feedback.
Let me see if I can figure that out. Now let's see if that's better. We are wrapping up this series today talking about vetting shared policies and external templates to make sure that whatever is shared with you in your organization, that it is implemented in an appropriate way and does not set your organization up for any potential liability or risk. Some of our learning objectives, of course, we talked about those in the beginning, and you can refer back to those at any time if you like. Now, why vetting matters? We have to talk about the vetting process when it comes to policies and procedures and why that's important. Because this day and age of healthcare, when there's so many things out there electronically, things, resource banks, things that are shared across organizations and even across the country, we have to make sure that whatever we look to implement in our organization is the right thing for our organization. Vetting is incredibly important because, again, we have a lot of sharing related to policies and procedures. There may be standardized order sets, clinical guidelines, toolkits. We create toolkits for all sorts of things. Even THA creates toolkits. We recently created, the most recent one, I believe, was the Workplace Violence Toolkit, or templates for how we can do things in the clinical area. So all of these things are fantastic when they're shared because it does save us a lot of time, but it only saves time if the content is actually thoroughly vetted and we make sure that whatever is in that toolkit, that policy, that procedure is appropriate to our organization and that we're not putting something into place that could actually create confusion. So, just a quick question to everyone. How many of you have ever implemented or reviewed a policy that contained the potential for a wrong department name? It may have contained an outdated rule or regulation or standard of care. Maybe it contained an incorrect phone number or referenced some type of equipment or something that you may not have, or a process that your organization does not perform. How many of you have potentially reviewed policies or had one implemented that contained something like that? Just a quick pop in the chat. My guess is, whether you want to put it in the chat or not, my guess is that most of us at some point in time in our career have encountered policies and procedures that were very outdated, or contained information that did not apply to our organization at all. Jody says all of the above. Highly likely. And unfortunately, that is commonplace. It happens frequently, and thus the reason that we have to vet our policies and procedures to make sure that they are free of these type of things. So some of the benefits to sharing are absolutely that it saves us time. There is really no point for any of us in this day and age to have to reinvent the wheel when it comes to policies and procedures and things like that. All organizations should be following the same standards of care. There may be specifics to your organization, but the standard of care is the same. So sharing of policies and best practices, this helps reduce duplicated efforts. It promotes consistency, not within one organization or system, but across the healthcare systems, even across a region, across a state. It incorporates those best practice. It helps support everyone in the regulatory readiness and of course accelerates implementation. It takes so much more time to have to go to the drawing board and evaluate everything, look up all of the best practice, look up all of the resources, and then put the language together to create your own policy. Certainly having one shared with you makes it so much easier and faster to implementation. They can provide us with that evidence-based practice. These are all of the benefits, basically, to having shared policies. We get access to someone else's proven workflow. Um, just because one organization is struggling with an issue does not mean that no other organization out there has struggled, not struggled with the same issue. Most of the time someone has, and they've already found a way to solve that problem. So why not share that proven strategy with others to make their journey a little bit easier as well? Most of the time, you have expert developed content. It goes back to those subject matter experts who have all of the seats at the table to help come up with these policies and procedures. I brought up, I think, in the very beginning, talking about how Vanderbilt had shared their antibiotic stewardship protocol with everyone at the beginning of the HIN program when antibiotic stewardship was becoming a condition of participation for all hospitals. They have are a huge institution that has the resources and the subject matter experts to do all of the research and put a document like that together, and they were happy to share it with everyone. It would also provide you with the current regulatory references. Of course, the time savings, we cannot minimize the time savings, and collaboration across organizations. We hospitals may be in competition with each other, so to speak, in that we have our area that we serve, and we look to have the patients come to our organization. So there is a little bit of competition that goes if between organizations when you have another one that's not too far from you. But when we collaborate together, we're doing the best thing for our patients and our communities, and not just what's best for our own organization. There are always hidden risks to taking a borrowed policy. Certainly, regulatory noncompliance. If you don't fully vet a policy or procedure that's been shared with you, you would not know if something in that policy is out of compliance with current standards. CMS conditions of participation may have been updated or changed. There may be new national patient safety goals with Joint Commission. Something may be outdated in that policy that makes it non-compliant. An operational mismatch, this would be a reference to something in that policy that is not suitable to your organization. Maybe it references a service line that you do not provide, like a potential women's services or something like that. But there's something in there that does not align with your organization's operations. Confusing responsibilities. Not all policies and procedures are written in a clear manner to where everyone can fully understand what their role and responsibility is. When that confusion happens, then it makes it very difficult for people to align with or comply with the policy or procedure. And of course, survey deficiencies. If something is not clearly outlined and does not reflect the practice that occurs in your organization, that opens you up to potential citations. And all of these things can lead to patient safety concerns. We run into the copy and paste trap. It's very easy to copy and paste things. And I think that we have to be very aware of this today, not just in terms of having policies shared with us from another organization, but a lot of people are starting to embrace AI and the abilities that it has and the tools that it offers to you. And it's very easy to type into AI and ask it to give you something. And it will. It will very quickly put out a product for you in a complete paper. And that's fantastic. However, AI is only as accurate as the information that it is fed and that it learns off of. And so you still have to be very careful of copying and pasting things like that, whether it comes from an AI source, some type of a policy software that you have, or from another organization. If it comes from another organization or if it's some type of a sample policy, if you do not read it thoroughly, sometimes there's another hospital name or a fake entity that's still present in the document somewhere. And so that can create issues. You may have different department titles. Maybe in one hospital, they called their medical surgical unit, and in another hospital, they call it the intermediate care wing. So you may have different department titles, which can be confusing to staff. Again, obsolete regulations, we always have to be mindful of those things. They may reference the wrong forms for your organization or wrong phone numbers. Area codes have changed over the years and in different places. Sometimes they add multiple area codes that maybe are within the same region or something has changed, and a wrong number is listed, which would make it very difficult for someone to call if they needed to verify something. References to unavailable equipment. Maybe it's something that your organization doesn't even have. A different EHR screenshots. Not all hospitals utilize the same electronic health records. And if your policy was copied from another organization, and it contains screenshots from Meditech, but you use Cerner, that's a problem for staff when it comes to following a policy or procedure. And of course, services that your hospital does not even provide. I would be curious how many of you used to provide labor and delivery services, and you no longer have a labor and delivery service in your hospital, but you haven't retired some of those labor and delivery policies. Now, take an example like this. If you have a rural hospital that adopted a restraint policy from another organization, and after it is implemented, 6 months later, surveys come in and identify that there's outdated CMS language, documentation requirements that were no longer required. It didn't have the appropriate approval authority, and it references a behavioral health unit, and the hospital doesn't actually have a behavioral health unit. That is actually patients are put onto their medical surgical floor. So, what went wrong here? What kind of things can you identify someone did or did not do that created this type of confusion that can lead to citations from a surveyor? And I'll give a moment for you to put some things into the chat. If you're thinking potentially that someone did not take a look at the CMS rules and regulations and conditions of participation to make sure that they were accurate and up to date, clearly someone did not do that. If it didn't go through the appropriate approval authority for that organization, we talked about that last week. All policies and procedures need to follow the same standard of approval in an organization. And certainly, again, referencing a behavioral health unit that a hospital does not have, you want to make sure that for consistency's purposes and to avoid any confusion with staff where that could lead to potential patient harm, that those things are identified. So some poorly vetted policies certainly can contribute to those survey findings. Operational failure is an absolute patient safety risk. Some of those common survey findings would be references to outdated CMS or Joint Commission requirements. These may result in regulatory citations or deficiencies. If you have staff practice that differs from your written policy, then they cannot demonstrate that compliance in an interview. So when a surveyor comes into your organization and they're talking to the staff members, if they do not speak to their practice directly as it relates to your policies and procedures, then that is a deviation and can result in a citation. If your policy does not match your workflow, that's inconsistent patient care. That means that everybody's doing things different. You have no consistency, and that can result in a lower quality of care. It can result in a higher cost to deliver care, and then, of course, ultimately result in potential patient or employee dissatisfaction. If the responsibilities are assigned to departments that are no longer existent in your organization, then of course there's confusion, and where would you place accountability at that point? When it references unavailable equipment or technology, how can you follow a written process if it's referencing something that you do not have to complete that process? And of course, policies that are not reviewed after they're adopted, you have to make sure that the most current policies and procedures remain in circulation. So that brings us to the VET framework. This is an easy framework to verify any policy and procedure, anything that may be shared with you, or even your own current policies when you're looking to update them or potentially if they're ready to be retired. But VET stands for verify, where you would look at those regulations, any evidence-based practice, and look at the references for currency. Evaluate, that would be taking a look at your operational fit, the resources that you have, technology and workflow, and how those align with the policy that you're reviewing. And then tailor, meaning that you customize that. You make that your own and you make it fit your organization. And that's where you come up with your education and your implementation and then your ongoing monitoring of that new policy or procedure. So remember that your surveyors will evaluate three things. They will look at your policy. They will look to see that your practice relates directly to that policy. And then they're going to look to see if the documentation supports the practice that refers to your policy. If those three things do not align with each other, then your organization can be vulnerable in a survey. Remember, alignment equals compliance. As long as everything refers back to each other, then that would be compliance. So where should you verify? Some of the first places that we would look would be CMS for conditions of participation. And of course, if you're surveyed by Joint Commission, you would look at Joint Commission standards. If it's DMV, you would look there. Any other, and I believe there's now one or two other agencies out there that are doing surveys, accreditation surveys. And so whoever is doing your survey, then you would want to make sure that you looked at any of their applicable requirements. Texas does have laws and regulations and, of course, licensing requirements. And so you would want to make sure that in addition to any federal or accreditation requirements, you're also meeting Texas requirements as well. OSHA, of course, as an organization, the CDC has a lot of guidance out there with how certain things are managed. And if you think about COVID and you think how rapidly things changed during COVID, we were probably updating standards of care and practices on a daily basis and sometimes more than once a day, depending upon what was coming out at the moment. We have all sorts of professional organizations out there, from medical organizations for providers, physicians, where you would get clinical practice guidelines and things like that. We have professional organizations for lab services, for pharmacy. So we always refer to our professional organizations for their recommendations. And of course, then you would look to your organizational bylaws and what services your organization actually provides, the service lines, and how you operate as an individual organization. When you look at CMS conditions of participation, you always have to evaluate that any policy or procedure supports their expectations in terms of patient rights, your nursing services and their responsibilities, infection prevention, and of course, quality and process improvement, your medical staff oversight, and your governing body, which is your board. So your CMS conditions of participation are very descriptive to those things, and you want to they have a lot of expectations, so you want to make sure that any policy and procedure reflects that. When we think about Joint Commission, there are national patient safety goals, and they also have set up some leadership standards, also performance improvement and infection prevention, and then looking at medication management and, of course, documentation expectations. We are trying to do our best to provide some documentation education to your frontline staff because we know that documentation, when it comes to that, if it's not documented, it isn't done, and you have a hard time supporting the hard work that your organization does if you do not have things documented. And that includes your quality and process improvement program in terms of not only collecting your data, but showing your documentation for your process improvement activities in your minutes of your committee meetings all the way up to your board meeting. So that documentation is incredibly important. Again, state requirements do matter as well. So we have to make sure we're always asking ourselves when we're looking at a specific policy, is there some type of a state rule or regulation required as an additional element to that policy or procedure? And what are the license requirements? Because if does this require someone to carry out this action that actually is a licensed individual, or can this be a duty assigned to someone who is not? Does it require specific language, or does the policy reference any outdated statutes? The best example here is workplace violence. In Texas, we have recent legislation that came into play, and there was specific language in there as to the type of committee that an organization needs to have to address and discuss workplace violence, even down to the people who were participating in that, so that the intent being that frontline staff can be involved in the conversation and that it isn't all high level management that are having the discussions and leaving frontline staff out. So you have to make sure that you're going back and looking at the most current legislation for the state, as well as any rules or regulations that we have for being licensed to provide care. Professional standards have to follow current best practice. Again, CDC and the guidelines that they put out. There are other organizations out there, such as AHRQ when it comes to healthcare quality, APIC for infection prevention, AORN, AACN, you have TMA for the Texas Medical Association, AMA. So there's all sorts of broad professional organizations that help produce the standards of care, but then we even go down to specialties from there. So you may have the Texas Medical Association, but then you've also got specialty organizations for pediatrics, for gastroenterology, for ophthalmology. So you can get down to some specialty organizations there as well. So is your evidence current? We again have to make sure that whatever we're using for a policy and procedure, or when we're looking at one that has been shared with us, we have to look at when it was written and when it was last reviewed, because it may be a policy that was originally written in 2000, but it was recently reviewed as recent as last year. So everything was made current. You still have to make sure that all the references are current, that none of the regulations have changed in that time. And again, going back to the example of COVID, that was such a fluid situation. And as rapidly as things were coming out in terms of best practice, they were changing. And so this was something we had to stay on top of on a regular basis. Some of the common red flags that we see references that when there's a reference to a withdrawn standard, something changes. Again, COVID. We are practicing masks, and then maybe they say we don't need masks in this type of situation, or whatever the case may be. We can't have visitors, but then yes, we can allow some. So there were different standards of care that changed regularly. Broken hyperlinks. How many of you actually click the hyperlinks when you look in a document and you're evaluating it for accuracy? Because there's possibility exists that a hyperlink is there, but once somebody tries to click on it to look up that reference, it no longer exists. Outdated citations. What about referencing organizations that no longer exist? IAFN had become the gold standard in terms of forensic nursing, and those seeking to be credentialed and certified as sexual assault nurse examiners. And earlier this year, IAFN underwent a huge fraud issue that basically shut the organization down. And so, what about all of the organizations out there now that had built policies and protocols around things that IAFN had put together and put out? But now it no longer exists. It does not mean that the work that they produced is bad, um, but now there's no organization to reference. The Emergency Nurses Association has absorbed a lot of the responsibilities for certification and things like that, but now everyone would have to update things to current organizations that support whatever that best practice is. What about obsolete terminology? Or certainly something that references superseded regulations. Before you approve any type of policy, it's important to again confirm that current regulations have actually been reviewed, as well as any applicable accreditation standards, that your state requirements have been evaluated and it complies with those. All references are up to date. If you have a subject matter expert available to you in whatever the area is, that review has been completed. If it's something that needs to be reviewed by your legal team, if you have one or outside counsel, that's absolutely appropriate on some items. And of course, that it supports your organizational practice. So, how many of you would approve a policy that had the simple statement, the organization follows the 2018 CDC recommendations regarding isolation precautions? Or what questions might you ask before approving? Since it's 2026, I might ask the question if the 2018 CDC recommendations have changed, if there's been any update, if that is in fact the most current recommendation, or has anything changed? And when you look at isolation precautions, is this is isolation precautions related to a specific um, matter or something a little bit more in general? But there's still some specifics here that are left that could leave things open for interpretation. So now you need to evaluate. Again, does a policy fit your organization? You have to make sure that whatever it is, it reflects how you deliver care and what your current service line and everything else is in your organization. And is it something that your staff can consistently follow? Is it safe and reliable when it comes to operations and supporting that? Just because a policy is compliant, it does not mean that it can be operationalized within your organization. And if you have policies in place that cannot be operationalized, those are still poor policies for your organization. So you have to make sure that it can actually be put into practice. So you have to evaluate your workflow. What is your current workflow and your actual clinical practice? And who are your departments that are responsible or what their current responsibilities would be? We always evaluate our communication pathways because we need to know who's going to disseminate information, who reports to who, and how things happen in the process, and what is your escalation process within that framework. When it comes to operational readiness, we have to consider if we even have the appropriate staffing to carry out the policy or procedure that we want to put in place. Have we done the competencies and have we evaluated everybody and tested them by competency to show that they are actually ready to do whatever we're asking them to do? When it comes to equipment, if it is something that we do not have, we would not want to put out any type of a policy or start that process until we actually had the equipment. And when it comes to technology, everyone's technology is different and everybody's levels of technology are different. So some of you are able to have a really robust IT personnel who can manage that type of thing for your organization when it comes to technology. But some of you are still incredibly rural, and so you might be a little bit challenged in terms of bandwidth and things that would be needed to support a process. What about adequate supplies? And if you do not have leadership support, that makes it very hard to be successful because we have to have that support from the top down to keep everybody engaged and motivated and pushing forward so that we comply with any change that's needed and we reach our level of success. When you're assessing your technology, does your technology support the policy? AI is a fantastic example because if your technology cannot support the use of some of those tools, then why would you have a policy saying that they can be utilized? Um, we have to consider our electronic health records. They are not all created equal. Some of them are easier to utilize, and some of them are easier to talk to other systems and things like that to integrate. And so they're not all the same. Clinical decision support. What about our documentation templates, reports and dashboards, our barcode scanning, smart pumps? Everything is smart something now. Most homes have smart thermostats, smart stoves. You can have a smart washer and dryer. But just because you have all of these smart tools does not necessarily mean you can control them from one source and one app. You might have to have multiple things to do that. And our alert systems, we have to make sure that we're assessing our alert systems to make sure that anything we're doing does not end up creating a barrier to our staff being able to hear or respond to any alert that's provided. We have to take a look when it comes to equipment and resources. Do we even have it? Or are the supplies actually available? What about our vendors? Does this mean you're going to have to switch a vendor for a certain product? And does every unit have access? And what are the maintenance requirements that need to be addressed? Because your maintenance department is going to have to be included. Some examples there when we start looking at specialty beds or infusion pumps. What about lift equipment? We have such a huge portion of our population now that is considered morbidly obese. So there are all sort of assisted devices out there. Which ones does your organization have? And is that the equipment that's referenced in a policy and procedure, or is it something different? Isolation carts, emergency equipment, again, all of these items are the same, but not, because a lot depends on which vendor you may get them from. They may have a lot of the same things in them in terms of a cart for something, but it depends on the vendor as to how it's arranged or how it's set up and how it's used. And then when you have a lot of travel nurses or agency nurses that are working in different places, that means they're being exposed to a lot of different things. So when you go to make change or implement policy, you have to make sure that education is provided thoroughly across the board. We always have to consider human factors and make sure that our policies and procedures are easy to read and that people can follow them. Again, if it's not easy to understand, that is going to make it difficult for someone to comply. And are the responsibilities clear? Is the workflow realistic? Or does it add an unnecessary burden on your staff to complete a task? Because if a policy is too difficult to follow, or if it creates an unnecessary burden, staff will find a way to work around that policy and that task to make it easier and more efficient for themselves. Nurses are good about finding workarounds. And so the whole point is that we standardize our processes and we eliminate that. So you have to make sure that we take the human factors into play and eliminate the potential for that to happen. When it comes to tailoring, you have to make sure that it fits your organization. You can take any policy and procedure and make it your own. You just want to make sure that it is customized with your organizational name and logo, that your specific department names are throughout the document, that you reflect your current job titles in your organization. We have hospitals that refer to their nurse executive as a chief nursing officer. We have some organizations that refer to that position as director of nurses. And so, whatever it is in your organization, that's how it needs to be reflected in your policies and procedures. Whatever current forms your organization uses, current phone numbers, your committee names, those may be different. You may have your quality improvement committee. Someone else may call it QAPI, QAPI. So you have to make sure that it is very specific to your organization. It's not as easy as just putting a logo on a document and then making it official. You have to really, really be specific to that. You always have to make sure that you do a cross-departmental review and you want to include everyone. Everyone should have a seat at the table. Nursing, med staff, your pharmacy, lab, radiology, your housekeeping, maintenance, because we sometimes do not realize how a policy or procedure for one department is going to impact another. And so it's really important that everyone have a seat at the table to evaluate those and see how it's going to impact their role within your organization. The other thing we have to make sure that we remember is that nursing needs to include physicians rather than me trying to steer physician practice. I need them at the table to understand what their current process is, because what I think might be good may not work for them at all with their particular role. And as a nurse, I would not know that. The same applies to having radiology try to direct nursing practice. So you want to make sure that everybody is at the table that needs to be. You need to do an operational fit score to look at whether your workflow matches the practice, your staff understand their roles and responsibilities, whether or not the technology that you currently have in your organization is going to support that process, making sure that you have the equipment, that the education has actually been provided before you roll out any type of new policy and procedure, and that any competencies that are required have actually been done, and that you have adequate resources available to your staff. Just a quick example, you may have a hospital that adopts a falls prevention policy that requires bed alarms for very high risk patients, hourly rounding, two-person assists for all high risk transfers, and electronic documentation every hour. So, with a policy like this that a hospital is looking to put into place, what are some operational questions that should be answered before this policy is actually approved? You should be asking things about your staff. Do you have the adequate amount of staff to cover this type of work? You're talking two-person assists for transfers, bed alarms. Do you have that equipment and do you have enough? Hourly rounding. What about electronic documentation every hour? Do you have enough documentation stations? But again, going to staff time, that's time consuming. So there are a lot of operational questions here that would have to be answered to determine if something like this would actually fit into your current practice. So when we put everything all together, from policy to practice, you absolutely have to have your leadership commitment to start, because that is what drives success in our organization when our leadership supports what we do and what we need to do. Staff education is absolutely essential to the success of any change. Everyone has to be fully educated and understand their role and responsibility in things. They need to understand the why behind what we're asking them to do, because just going in and telling someone you're going to change things and this is how you need to do it now, that's going to create a barrier to facilitating change. We all have the need to understand why we're having to do something the way we're having to do it now. Workflow integration, making sure that anything that we implement is not going to create an undue hardship on staff to actually do it, that we make it more efficient for them to do their job. Communication is key at all levels. And of course, we have to have continuous monitoring and improvement of anything that we do when we're looking to implement change. You have to build the right review team. Again, those subject matter experts are going to be key. And you have subject matter experts in your organization. You just have to pull them to the table and utilize them. You have clinical leaders. Quality is always important to have a seat at the table when it comes to policy and procedure review, because they need to look at it from a quality lens to make sure that it meets standards of care and it's going to not pose any type of a risk to you. Your risk management, again, legal when appropriate, infection prevention, your IT and informatics, and of course, always include your frontline staff because they are the ones actually at the bedside providing the care. And so they will be able to be the ones to provide you the best input as to something that you want to implement and how that would impact their current workflow. Governance absolutely matters. We need to know who is going to own the policy. We need to know how it's going to be approved and by who's going to maintain it, who's going to review it when it needs to be revised and do those revisions and submit them for approval, and who is going to be responsible for staff education to make sure that they are given the tools that they need to actually be in compliance. Successful rollout looks like providing staff education. You have to make sure you have competency validation. Again, making sure that everyone is fully ready before you roll something out. Simulation when appropriate. If it were a new cardiac monitor that a defibrillator, then you would want to make sure that you go through some type of simulation exercises to make sure everybody actually uses it correctly. And so sometimes that's the best way to check a competency. Any updated job aids or information that can be provided, what the communication plan is going to be, so that once things are rolled out, if staff do identify issues, who do they communicate that to? Who is that person that they can go to and say, hey, this isn't working just right. Here's something that we've identified with this new process. And then, of course, questions and feedback. Everybody should be able to ask the questions they need, provide any necessary feedback so that you can evaluate if this process is going to work, if it needs to be tweaked a little bit and some modifications made before you move forward, so that whatever you're doing is in the best interest of not only your staff, but your patients. When you communicate the change, do not simply use one method to communicate change. We have staff meetings, but we do not necessarily have staff meetings. How many of the same meeting do you have? Because you have day shift, night shift, but even with the day shift and night shift, everybody's on and off at different times. And so, are you able to actually capture everybody in a staff meeting? We have emails, but how many people get behind in checking email? Huddles are great, and everything. You have unit champions, visual reminders, leadership rounding. There's lots of different methods to communicate change or to relay messages. We just have to make sure that we utilize more than one. Monitoring for compliance is all part of quality improvement. You should have some metrics set up anytime that you implement change. We want to make sure that they're following the policies, that we're as leaders reinforcing expectations, that it is documented, that we're supporting our practice through that documentation. And as we identify any type of barriers, that we're actually addressing them or doing something about them. We audit our effectiveness. Again, we do chart reviews. This may be through direct observation, tracer activities, it may be competencies, performance dashboards, patient outcome measures. These are our quality metrics that we utilize to make sure that whatever we're doing is actually working. Avoiding that policy drift that we talked about the last time, that occurs when practice changes, but your policy didn't. Again, some of the signs of that include those workarounds that staff will find, different practices between different departments, staff uncertainty. They're not quite sure what exactly they're supposed to do, or it may be found on survey findings, or again, those outdated references. The review and revision cycle, anytime regulations change or standards change, if your equipment changes, your workflow processes, you have done a new service line and that's changing how things flow through your hospital, whether you have survey findings or not, or you have safety events, all of these things would be appropriately signaling a review and potential revision of a policy or procedure. We do not want to be just hard and fast on a calendar, because it hasn't been a year since our last review. We can wait. We want to make sure that we're reviewing and revising as needed, and as things occur. Some of the red flags to policies and procedures: if there's no policy owner, it's not clearly defined who's responsible for it. Those outdated references or wrong departments that may be listed, wrong equipment. It may be referencing old forms. Think about whatever forms you utilize when you have downtime, when your electronic systems go down and you have to revert back to paper charting. Is that the current forms that you're supposed to be using, or are there still copies of some outdated form? Those broken hyperlinks, we have to make sure we check those. Undefined acronyms when we're throwing things out there that nobody else really understands. If the workflow does not match the practice, and of course, there's no education plan or no monitoring process to something that you went to put together. When we put the vet framework together, when we verify, we want to make sure that whatever that process is, that it's compliant. We evaluate it by making sure that it's actually going to work in our organization, and then we tailor it, meaning it becomes specific to us and how do we safely implement it to reflect what we do as an organization and not the organization that it came from. Final takeaways. Before adopting any shared policy, always make sure that you ask if it's current. Is it compliant? Is it actually going to fit your organization and the care that you provide? Have you actually customized it and make sure that only your hospital name is throughout and referenced, and everything fits your specific organization? Have you adequately prepared your staff? And how are you going to measure your success? Because we always have to have a means to test change. I am going to continue on with a little bit of information, but I'll open it up for any questions or anything else. If you have them, please go ahead and pop them into the chat. But I want to, before everybody jumps off, make sure that you know we've got our frontline staff education. We have one more in-person training in Austin that will be August 14th. And we'll spend half a day talking about documentation, and then the afternoon will be quality improvement and infection prevention. And then our frontline staff webinar series begins next week. And we will be covering things like how to have some of those conversations with patients and families to improve the patient experience, which would improve your patient satisfaction scores. We'll talk about quality improvement with them and what the frontline staff role is. Again, those events are appropriate for all frontline staff, whether they are with housekeeping, with maintenance, lab radiology. The information is appropriate to everyone. We do give nursing CE for each one of those. The webinar series will be a total of 3 if they attend all 3 webinars. And then the in-person event is 6.75, I believe. Judy just dropped a link into the chat box where you can find the full event calendar at THA, and that's where you can find the registration information. All of these events are free to anyone from a critical access hospital. Unfortunately, we do have to charge people who come from a rural hospital, but it is minimal. The webinar series is $10, which covers the cost of a CE certificate. And I think that the in-person frontline staff one is about $20, I think, to attend that for 6.75 CEs. And so we just aren't able to use any of the MB grant funding for outside of critical access hospitals. There's also a link in the chat box to our landing page, which is where you can find any of the recordings for the previous webinars. And so the first two are already posted there. And then if you'll just give us about 24 to 48 hours, this webinar will be posted there as well. So I'll give it just a minute to see if anybody has any questions or comments. Again, please feel free to drop those in the chat. And I will put my contact information up there. If you have any questions or anything else, please feel free to reach out to me. There are going to be some resources at the end of this slide presentation, and we'll get the slide decks posted as well once this whole series is complete so that you can download the slide deck if you like. Judy also popped in the link into the chat box that is for the CE certificate. You just go there, click the events that you attended, and answer the questions and claim your CE. Each one of these webinars will get you one continuing nursing education credit. With that, thank you so much for joining us today. We really appreciate all of you. We hope to see a lot of your staff on our Frontline Staff series beginning next week. And we always have a lot of fun with that. And we hope to see a lot of your staff come to Austin and spend the day with us in August. It is probably going to be warm, but we'll take them up on the rooftop and show them a beautiful view of the Capitol and hopefully help them improve documentation. So we look forward to seeing them there. If there are no other questions or anything else, we'll give you back just about 8 minutes of your day. Again, thank you for joining us, and we hope that you have a great rest of your week.